Committee of the Health Commission Community and Public Health Committee meeting of Tuesday, April 19th, 2022 to order, please.
And I will call roll. Commissioner Dorado?
Here.
And Commissioner Chong?
Here.
Thank you. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. And Commissioners, item 2 is the approval of the minutes of the Health Commission Community and Public Health Committee meeting of March 15, 2022.
I move to approve the minutes of March 15th, 2022.
And I'll second the motion.
Great. And before I take that as a full vote, I will just check there's somebody on the public comment line to make sure we don't have any public comment. Person on the line, if you'd like to make comment on item 2, which is the minutes from the March 15th meeting of this year, please press *3 now so we can recognize you. *3. All right, no public comment, and I will take both of your actions as a vote and approval, so thank you. We can move on to item 3, the Housing Conservatorship update, and I will pull up the presentation. Give me a moment, please. Does it look okay to y'all?
Looks good to me.
Okay, great. Thank you, Dr. Almeida.
All right, good afternoon, commissioners. Always a pleasure to be here. And so let me go ahead and transition to talking about housing conservatorship and what's happened over the last year since I was here last. Next slide, please. So just to reorient us to the conversation, just a reminder that housing conservatorship is specific legislation that's designed to support individuals who are cycling in and out of a psychiatric crisis, who are unable to care for their health and well-being, have declined any voluntary services, and are not eligible for other programs that we have, including assisted outpatient treatment, which of course we'll be talking about later today, as well as LPS conservatorship. Next slide, please. There's very specific criteria for housing conservatorship, so this is just to name a few, but this program is unique in that an individual has to be diagnosed with a serious mental illness and a substance use disorder. The part of the intention of this legislation is to support individuals, again, who are cycling in and out of crisis, whose mental health may be exacerbated by substance use. They end up in a crisis, may go to the hospital on an involuntary psychiatric hold, but when they're no longer under the influence of substances, their mental health symptoms stabilize, they're released. This cycle continues and they deteriorate over time. This, of course, leads to functional impairments for the individual where they're unable to care for themselves. And some very specific criteria under the legislation is that they have to have 8 or more 5150s in a 12-month period. What's important to note here that it's not based on a calendar year or fiscal year, it's 12 months specific to that individual, but there has to be 8 or more 5150s with very specific language in the documentation about their hold and their offer of voluntary services at each contact. The other piece, of course, is that we have to have well-documented information that an individual has been offered those voluntary services, and specifically starting at the 5th 5150 or involuntary hold, an individual received notice that they're on the pathway to housing conservatorship, how many more 5150s would lead to them being considered for housing conservatorship, and the voluntary care that they've been offered. Next slide, please. So this just provides some contextual information. And of course, we are fortunate enough to be in an opportunity now where we're able to look at data over a period of years. So this starts on the left, of course, with fiscal year 18-19, and then through fiscal year 2021. And so this shows the number of individuals who have 4 or more 5150 holds in the darker blue, and then in the teal for individuals who have 8 or more holds. Again, this is important to highlight because starting at the 5th 5150, we notice individuals that they're on their pathway. And so we really start to look at cases who have a higher volume of 5150s, particularly those who have 4 or more. And then, of course, for the individuals who have 8 or more, we are looking at filing petitions for housing conservatorship if we are unsuccessful in serving them in voluntary care. And so you see this number has fluctuated over the last couple of years, and most significantly, we've seen a decline in fiscal year 2021. Next slide, please. So for our annual update around housing conservatorship, and I believe that report was also provided, our data focuses on fiscal year 2021. And so just to share some highlights between fiscal year 2021 and then where we're currently at in this fiscal year. So in fiscal year 2021, there were 3 petitions filed for housing conservatorship. This is significant because up until that point, we were unable to file petitions. There was a lot that needed to be done in terms of preparing court orders and partnering with the court to make sure everything was in line to be able to move forward. So this was our first opportunity to attempt to move forward with these cases. In total, 25 individuals received notices that they were on the pathway to housing conservatorship. And of course, as is true in all of our programs, our legal and ethical responsibility is to serve individuals in the least restrictive setting. So our primary goal is always to support individuals to accept and engage in voluntary services, and really for conservatorship and these more restrictive tools to be used as a last resort to support individuals. So in fiscal year 2021, we had 14 individuals who accepted voluntary services, who were connected to care. Of those 25 who received those notices, and 12 individuals received support and no longer met criteria for conservatorship after that. So we had a lot of success in supporting individuals to stabilize in the community and reduce their contact with crisis services. Now, where we're currently at in fiscal year 21-22 is there are 2 individuals who are being served under housing conservatorship. When I drafted this presentation, there was 1 petition pending. That has since gone through. And so now we have 2 individuals who are being served under housing conservatorship. 1 conservatorship was recently dismissed. So we still are at 2 who are being served. Similar to fiscal year 2021, we have roughly the same amount of individuals that we have been serving that they're on the pathway to housing conservatorship, and that's been 23 individuals. And of course, we again will be tracking very closely how successful we have been in supporting individuals to accept and engage in voluntary care. Next slide, please. So just to provide some additional population level information. So again, we look at both individuals who have 4 or more 5150s and those who have 8 or more 5150s that can be considered for housing conservatorship. One thing that's important to note is that there are roughly 13,000 5150s that occurred in San Francisco in fiscal year 2021 across the different hospitals. One of the challenges we face is that we don't have client level information from other hospitals outside of general hospitals. So our most specific information that you see here is from psychiatric emergency services. Just to note that this is an area of opportunity, and we have been working very closely with the Hospital Council of Northern California and individual hospitals to work on updating LPS delegated agreements, which will provide us with a lot of opportunities, particularly around data sharing, both at the population level. So we have a more holistic and complete understanding of the rate of 5150s across San Francisco, outcomes for individuals, so that as we make policy decisions, we can be data driven and informed in those decisions. Also, very importantly, it'll allow us to have client level information so that we can be more proactive and intentional in our outreach and engagement of individuals while they are at a hospital and as they are discharging from the hospital. And this work will be very closely aligned with the work of Mental Health San Francisco, including the Office of Coordinated Care, so that we can both make those connections for individuals and connect them to our larger system of care, and also for us to be more proactive in identifying individuals who might be at risk for other court-ordered services, including assisted outpatient treatment, housing conservatorship, or LPS conservatorship, so that we can more appropriately and effectively intervene in those cases and support people from deteriorating further. But the average number of 5150s at psychiatric emergency services for an individual is 2.3 visits a year. So just to note in terms of the smaller population that we're talking about who have 4 or more or 8 or more 5150s, that's a very small part of the population that we're supporting through the housing conservatorship process. So in fiscal year 2021, there were 92 individuals who had 4 or more 5150s. And just to provide some highlights, of course, that these are individuals who have higher rates of being unsheltered or experiencing homelessness, higher rates of using urgent emergent services, contact with a jail, and are less likely to be connected to ongoing services. Although we have had support in engaging these individuals in intensive case management or outpatient behavioral health care, and that's 41% of this population, or linking them to other programs, including LPS conservatorship. And again, this very small population of individuals who have 8 or more 5150s, you'll see it's pretty dynamic. Most of these individuals we've been successful in supporting to have access to coordinated entry so that they can be considered for shelter or permanent supportive housing, whatever it takes to support them along their pathway to recovery and wellness. And we have been incredibly successful in engaging and linking individuals to our larger behavioral health system of care, including residential treatment, outpatient behavioral health services, and intensive case management. And that's been 79% of cases. We also, of course, always assess individuals for other services, including LPS conservatorship, and 29% of these cases have been served through LPS conservatorship, as that was determined to be the most appropriate to meet their needs. Next slide, please. So I want to delve into a little bit of our requirements through the health code of our annual evaluation around housing conservatorship. And we are fortunate enough that we partner with the Housing Conservatorship Working Group to both evaluate the program, analyze the data each year, and also to draft the report. And so this just lists the 5 different requirements in the health code. A lot of these requirements focus on the effectiveness of the program, which we have limited data for currently, since being able to initiate 51 or housing conservatorships through this process is newer, and individuals at the time of evaluation were still being served under housing conservatorship. But it also affords us with an opportunity to look at that population landscape of 5150s across San Francisco, the impact of police being involved in 5150s, and how we are otherwise able as a city family to support individuals who are experiencing a behavioral health crisis. Next slide. So this is addressing specifically requirements 1 through 3. And again, this is very focused on individuals who are placed under a housing conservatorship. So as I previously noted, 3 petitions were filed during fiscal year 2021. 2 individuals were ultimately placed on a conservatorship. And at the end of the fiscal year, we're still being served through housing conservatorship. When we look at requirement number 2, this is really looking at the effectiveness of the program. Again, because individuals were still being served under housing conservatorship, the effectiveness was not fully able to be assessed. But what we do know about these individuals is that prior to being placed on a conservatorship, neither were engaged in behavioral health care, and we had been unsuccessful in supporting them to accept voluntary services. And of course, while each individual's treatment plan is individualized to support the unique and complex needs of each individual, some services that were provided include psychiatric respite, intensive case management, psychiatry and medication management support, peer support, and remaining in the community or in the housing that they originally had with intensive wraparound services. Of course, we talk about a lot of our programs, and specifically the housing conservatorship program being a whatever it takes and wherever it takes approach to support people. So how we really wrap around them to be supported in the communities where they feel most comfortable. And evaluation requirement number 3 specifically looks at the impact of conservatorships. And unfortunately, this was not something that we were able to evaluate at this time because the 2 individuals were still placed on a conservatorship. So more to come in that in future years. Next slide, please. And so I want to take an opportunity to spend more time on evaluation requirements 4 and 5. These are ones that we have significantly more data for. And again, still opportunity to have improved data collection here. But we have significantly more data for evaluation requirements 4 and 5 and over multiple years. So it gives us an opportunity to evaluate what this looks like in San Francisco over a period of time. So again, just to note, what we have been able to gather from multiple hospitals across San Francisco is that there were roughly 13,051 detentions over the course of the fiscal year. Again, we are unable to know how many of these are unique individuals who have multiple involuntary holds, or how many of them are a single hold that they may have had during the course of this time. That's something that we're hoping to improve through these updated LPS delegated agreements. And so we're hoping as the years progress, we'll have much clearer data here that we'll be able to share. What we do know for Zuckerberg San Francisco General Hospital is that there were a total of roughly 2,700 5150s that were seen at psychiatric emergency services, where 1,700 unique individuals accounted for those holds. And this data, I'll just say, comes in terms of the hospitals across San Francisco from CPMC, Kaiser, St. Francis Memorial Hospital, St. Mary's Medical Center, and UCSF. Next slide, please. The other thing that we, of course, presented last year that is always something that's important for us to contemplate is any unintentional impacts or disparities we see for the individuals we're serving, and particularly when we consider court-ordered or involuntary treatment. And so this looks at over a period of time, starting in fiscal year 18-19 through fiscal years 2021, individuals who have 4 or more 5150s, and the breakdown of ethnicity that we have for this population. Again, we only have the specific information from Zuckerberg San Francisco General Hospital, but we're hoping that in future years we'll have more specific data across our hospital setting. I think what's important to note, of course, is while we have the data for multiple fiscal years for individuals who have 4 or more 5150s, is on the 4th line for individuals who have 8 or more 5150s. And you see a pretty significant change in the population there, particularly when we look at how this compares to overall PES or psychiatric emergency services population, as well as the San Francisco census estimate. And so we see quite a significant disparity, particularly for individuals who identify as Black or African American. This continues to be a priority for the Housing Conservatorship Working Group to address this, and again, to respond to and contemplate any unintentional impacts of this legislation. We have not seen that thus far. Of course, we have a very few individuals who have been placed on a housing conservatorship, but I think it's really important for us to note. And again, as we get more information from our local hospitals and our partners, this will be something that we'll really want to monitor, and how we more intentionally develop our impacts and our interventions to support this population. Next slide, please. Our last requirement for the housing conservatorship annual evaluation is really to look at when 5150s were performed by a peace officer and why it was law enforcement that was called to the scene. And just to say, of course, that we know that there are many opportunities and many changes that have happened in the last year of diverting calls away from law enforcement, which I'll speak to briefly. So this is data that comes from the San Francisco Police Department, and it's related to 5150s that were initiated by police officers in fiscal year 2021. Next slide, please. And so again, this is comparing data from 1920 to 2021. And so these at the bottom are different call code types, or the reasons for the 911 calls. So you see suicide attempts, if a 5150 had already been placed and police were called to the scene, a mentally disturbed person, which is coded as an 800. I want to highlight the mentally disturbed person call for 2 reasons. One, of course, I want to note that this is really not trauma-informed language. This is old language that is used. The other thing that is really important to note that the street crisis response team was specifically designed to respond to these calls and are diverting these calls away from a law enforcement response. And so we'll see an impact for these numbers as we move forward. But I'll just say in the month of February alone, the street crisis response team was able to divert 62% of these 800B calls away from law enforcement. Well-being checks, and then assault and battery charges. So you see, like over the course of a couple years, their data is very consistent about the types of calls that they're receiving and when they determine that an individual meets 5150 criteria. Next slide. And this slide looks at their reason for 5150 from the police department. So when it was determined, and of course, we know that individuals sometimes were placed on a hold for multiple reasons. And so this is greater than 100%. But when an individual is determined to be a danger to themselves, a danger to others, or grave disability. So in most of these situations, when law enforcement are initiating a 5150, it's because they've determined that an individual is a danger to themselves and that they need to be transported to a hospital setting. Next slide. And so just to say, of course, happy to answer any questions regarding the housing conservatorship work that we're doing. And of course, for public information, we have the email address and information regarding the housing conservatorship working group, which are public meetings, and we of course encourage people to participate in.
Dr. Almeida, Commissioner Dorado sent some questions, and I just found them in my draft folder and forwarded them to you, but I apologize, Commissioner,
No worries.
and also to you. So I'm going to read them out loud. For slide 6, 14 individuals out of 92 went on to have, and if you can't answer them now, just please send me the info later.
Will do.
14 individuals out of 92 went on to have 8 5150s. Please explain the 79% and then the 29% of the 79% went on to LPS.
Yeah, absolutely. And so I am happy to address that as best as I can. And then Commissioner, please let me know if I don't fully answer your question, and I'm happy to follow up with additional information. So just to say, of course, that 29% of those individuals were ultimately placed on an LPS conservatorship. And individuals who are in LPS conservatorship can also be in the community. And so there's certainly overlap between individuals who are placed on a conservatorship who we also were able to link to intensive case management. And through being on an LPS conservatorship, we're able to remain in the community, remain stable on medications in some situations, and even in some situations maintain their housing that they were at risk of losing.
Okay, thank you.
And then the other question was for fiscal year 2021, what is the current status of the 23 individuals on the pathway to conservatorship?
These are for individuals who are on the pathway, some of which, and I think it notes here that some individuals no longer meet criteria for conservatorship. So we were successful in engaging in care and they are no longer on the pathway. There are some individuals that we have continued to engage in who may have accepted voluntary services, but may still have crisis contacts. So determining whether we are best meeting their needs or if they need a higher level of care or intervention to support them.
Okay, and I have one more question too.
Please, Commissioner.
And I think my video is frozen, so I am I'm still here. You had mentioned with that street crisis response team and how they've been able to divert some of the 911 calls, et cetera. What has been their added number to the 5150s? Do you have any of that information?
I do. And I would say like this is where we'll need to understand more about the impact. We're still while we're a year into the street crisis response team being implemented, we're still fairly early on in the project. And we are soon to be exiting from our pilot phase. And so always, excited to come back and talk about where we are in terms of that program. But I'll just say in general, cumulatively since the program launched in November of 2021, there have been 5% of those calls have led to a 5150 being initiated. And that's of close to 4,000 calls. So only in 5% of cases do they need to initiate a 5150 hold. What we anticipate is that by having a comprehensive team of a community paramedic, a peer, and a clinician who are able to engage individuals, support them in the community, de-escalate, transition them to appropriate behavioral health care. And the follow-up that we have through the street crisis response team is that we'll be initiating involuntary holds at a lower rate than we may see in other parts of our system. We, of course, know that involuntary holds is an important tool that we have, an important part of our system, and we want to make sure that it's used in the most appropriate way.
Thank you. One of the, from our last meeting when you presented a year ago, my recollection, it was the same number. 2 people had gone through the process to be conserved and were under conservatorship. And I know when I presented this information at, since I'm the commission's representative for San Francisco General Hospital Foundation, the board was really shocked and surprised when, et cetera. So I think that even though it's not part of your job, but I think that the public needs to know more of what I mean, in very simple terms, what the criteria is, because it's like I've heard it's more, just hearsay. Look at all these people, they should be conserved, et cetera, but don't understand the criteria through the legislation. So it's just it was a bit of a backlash, put it that way, of people, and I tried my best to explain, but I think any kind of information that is put out should really highlight, what it's the law. It's not DPH's wish, so to speak, but this is what the requirements are.
Commissioner, I really appreciate that. And just to say that there are absolutely limitations to the legislation, and it changed drastically from what was initially presented at the state level to what ultimately was adopted, and very strict criteria that leads to very, very few individuals, as you see, qualifying for the housing conservatorship process. And Mr. Morowitz, I'm happy to send you the fact sheet that we have, which has a flow chart as well, so that you have that as a tool. But I completely agree, Commissioner, that that's something that we want to make sure that the general public is aware of, because there are limitations that we have in terms of how we're able to leverage this as a tool. And I think opportunities for community members to be engaged in those conversations, both at a local and state level.
No, I'd appreciate that. And one of my other questions, whether or not it's appropriate now or after your presentation, you can tell me, is what is the possible impact of the governor's proposed care court? And is there any planning consideration through your group going forward?
Yeah, I appreciate that, Commissioner. And I'll just say, we just recently saw the initial drafted legislation around care court. There's a lot that's still to be determined, and of course, a legislative process. And I'll just say, as a city and county, we're very engaged in the state level conversation around care court, and how that would best meet the needs of the population that we're seeing in San Francisco, and providing subject matter expertise.
Okay, my hope is too, if all of a sudden they want to start it, that we know what we are going to do and that we have a jump on it, so to speak.
Absolutely. Yeah. And I'll just say, I think we're fortunate in San Francisco that we have a number of different programs and solution-focused courts through the criminal court process. And of course, we'll be talking about assisted outpatient treatment momentarily, but a really robust system and collaboration around assisted outpatient treatment and conservatorship. And so we want to make sure that, one, we of course are well planned and coordinated in that. And so we're not duplicative in our efforts, but that we're really leveraging the tools that we'll have available to us.
Great, thank you.
Commissioner Chung, any questions?
No, just one comment is that, with the care card, I think like my being mindful where the governor used to be. I think that, there's going to be a lot of like connections, to the existing system that we have, and hopefully that's what we are seeing, is that there's going to be a lot of connections to what we already have existed, because I think that the behavioral health court have done a phenomenal job to like working with defendants and keeping them out of jails. That's why our census has gone down so much, for the jails.
Thank you, Commissioner. And I will go to the public comment line. Person on the line, if you'd like to make comment on item 3, which is the housing conservatorship update, please press *3 now so we can recognize you. *3. All right, I don't see any hands. Commissioner Dorado, is it okay to move on to the next item?
Yes, please.
Great. I will pull up the presentation.
All right. And of course, I'm here to talk about assisted outpatient treatment again, which is always a pleasure. I think I've shared before, assisted outpatient treatment is how I came to the Department of Public Health to start the program and implement it. And so it's something that's very near and dear to me. And I'll just say a program that we're very proud of in behavioral health services. I'd also like to take the opportunity to introduce Dr. Wright, who's here, who is our current director of assisted outpatient treatment and also oversees our coordination around conservatorship services with the Department of Disability and Aging Services. Next slide, please. Again, just to re-enter the conversation around assisted outpatient treatment, this is a program that's commonly referred to as Laura's Law, based on the Laura Wilcox case in California. Historically, this was something that had to be adopted by a county. There's been recent legislation that now requires counties to adopt or have clear reasoning why they're opting out of assisted outpatient treatment. And so in the last year, we've seen the landscape in California shift slightly. But what this allows for is for court-ordered treatment for individuals who have a serious mental illness. This is unique and different from conservatorship, is that it does not allow for the petitioning of forced treatment or forced medication. So there is not an opportunity to pursue an involuntary medication order. So in a lot of ways, it's really less restrictive than either housing conservatorship or LPS conservatorship. But ultimately, it's supporting individuals who have serious mental illness, who are not engaged in care, and are on a downward spiral. Of course, ultimately, the goals of this program are to engage individuals in services, reduce hospitalization, incarceration, and victimization. Next slide, please. And so in San Francisco, we developed and implemented our assisted outpatient treatment program in 2015, and this really focuses on a community-based, mobile, and multidisciplinary mental health team that responds to individuals in the community. We strive very much to make multiple opportunities and engagements to support individuals in accepting voluntary services, and we've been really successful with that overall as a program. I already talked about our approach as a system, and this certainly applies in assisted outpatient treatment of this whatever it takes and wherever it takes approach to support people. Our teams are very field-based and in the community, meeting with individuals at hospitals, at their homes, in alleyways, really wherever they feel most comfortable and the best way to engage them. This is all rooted in principles of recovery and wellness and how we meet people where they're at. We support them. We engage them in engaging in voluntary services. We connect them to long-term care, and we provide that support over time. There's two different parts to our assisted outpatient treatment program in San Francisco. We have an AOT care team that is within the Department of Public Health, and so civil service staff. That includes a program director, manager, clinicians, and team members. The other thing that's really unique about assisted outpatient treatment, and I'll talk a little bit more about who can make referrals, but it's unique in that it specifically calls for supporting family members, and it allows for family members to make referrals into the program, which we don't see with other types of programs. And so we have 2 staff members who provide both peer support and family support to individuals. And I should, of course, say, when we talk about families, it's whoever individuals identify as their family or their support system. We also contract with UCSF Department of Psychiatry citywide to have a specific full-service partnership team that provides the intensive case management for individuals, particularly those who are court-ordered to participate in treatment. What's unique about the legislation for assisted outpatient treatment is that it requires a staff-to-client ratio of 1 to 10, so it's much more intensive services to support and stabilize individuals. And then, of course, we transition people to other parts of our system so that they can maintain over a period of time. As we've implemented this program, what we've seen is that the impacts of assisted outpatient treatment, and I'll talk a little bit more about this, but reductions in negative outcomes for individuals are maintained over time. So it's a very successful intervention that we've had in San Francisco. At Citywide, their team includes a clinical supervisor, clinical case managers, a psychiatrist, peer specialist, and a nurse. And again, they are very similarly field-based. Our teams partner very closely together. As the Department of Public Health, we see our relationships with individuals continuing even while they're working with the Citywide or their existing treatment provider. And so we continue to supplement and provide that support so that we, again, can really wrap around somebody and support them to remain safely in the community. Next slide, please. So who can refer into the program is very specific in the legislation. And it predominantly includes treatment providers, and as I mentioned, unique that it includes family members. And I'll just say family members are identified in the legislation as being a parent, sibling, or spouse of an individual. And as I already noted, this program and how we've implemented in San Francisco really leverages this opportunity to provide additional family support, psychoeducation, and partnership with an individual's existing support network and system. And just to highlight again, we've had a lot of support with engaging families, both in terms of reunification for individuals who had lost contact with children, for example, that we've been able to support that. We've also had some cases where individuals had come to San Francisco from other parts of the country, whose parents had made the referral because they were concerned about them. And we were able to support stabilizing them and returning them back home to their families, where they continue to do very well. Next slide. So this provides just some demographic information from fiscal year 2021, just to say what we've seen over the course of the program is that this data is very consistent from year to year. So we find that most individuals that we serve identify as being male, are between the ages of 26 to 45, and identify as being white or Caucasian. And this is 75 total individuals that we served in the fiscal year. Next slide, please. When we look at risk factors, what we find is that before we engage somebody in assisted outpatient treatment, and that can, again, looks at individuals that we're engaging in voluntary services who are referred or that we're assessing for their appropriateness. It's very rare that we actually need to pursue a court order because of our level of success in supporting individuals to accept voluntary care. But what we find is that prior to engaging in assisted outpatient treatment, individuals have high rates of psychiatric emergency services, inpatient hospitalizations, incarceration, and experiencing homelessness. And this is looking at the 3 years before we work with them in assisted outpatient treatment. Once we've supported them through assisted outpatient treatment, again, these gains have been maintained over a number of years. Individuals have significantly fewer PES contacts, hospitalizations, jail contacts, and are more likely to be in stable housing. I'll just say what we had after we implemented the program, we did a very robust 3-year evaluation. And what we found again is not only are these gains sustained over a period of time, but it's statistically significant reductions in these negative outcomes, just to highlight the level of success that this program has. Next slide, please. So just in terms of outcomes for this cohort that we served in fiscal year 2021, we were able to connect 60% of individuals to intensive case management services. Only 5 individuals we had to pursue a court order for, and were being treated under a court order. Again, what's unique about the court order is it's really leveraging the black robe effect or the symbolic weight of the court to encourage somebody to participate in care. There really are no enforcement mechanisms under assisted outpatient treatment, including not being able to put somebody in a hospital setting or a locked subacute setting, or have an involuntary medication order. Of course, because of the population we're serving, we're always assessing individuals to see if they need a higher level of care or if they meet criteria for a 5150 or involuntary treatment hold. And so we work to intervene very quickly to support individuals to have the appropriate intervention to meet their needs at any time along the pathway of us working with them, which includes some individuals do need a higher level of care. And so in 25% of cases, we work to connect them to an LPS conservatorship and supported that. Many of those individuals remain in the community. And ultimately, as you just saw, we have overall reductions in negative outcomes for this population. And then, of course, similarly, we have, if anybody needs to make a referral, we have a phone number that people are able to contact or an email address. We also have a website that's here that has additional information, including a fact sheet for our program and information about the law and how to connect to services. And we're always happy to support individuals, family members, and community members along this process. And as always, happy to answer any questions that you may have.
I have a couple of questions too. The first, which is when you were talking about the outcome data with the 60% with the voluntary, the intensive case management, are we talking 75 individuals, or what is the number of individuals that the data you're using for the outcome?
The denominator would be the 75 individuals.
It is the 75. Okay. And then what is the status of that 25% that were referred to LPS conservatorship?
So I would be happy to get you some more specific information, but just to say those, in many situations, those individuals remain in the community, but required additional support or an involuntary medication order to be successful to remain in the community. But I certainly can get you some more specific information about that 25% of individuals. And can I ask, Commissioner, is it specifically in terms of placement that you're interested in, or just if those individuals were ultimately placed on a conservatorship?
Yes, I think it's like, okay, with those 25%, they're going on the road, so to speak, to what are the interventions that you have found that were basically unsuccessful for that 25% to be referred to the conservatorship. So I'm always looking to see what are those factors.
Absolutely. And again, I'll provide some more specific information, but just to share anecdotally, there are some situations where individuals may start with an AOT court order, and we're unsuccessful in stabilizing them through that process. And so it's stepping them up to a higher level of care of LPS conservatorship as appropriate. There are some individuals where it's clear as we're working with them and engaging with them that they really need that higher level of care. And we, of course, want to make sure that we're matching the intervention to what that person's need is. And so we provide that support as well. But I'm happy to get you that specific data of how many individuals went immediately to a conservatorship that we were able to identify and support that intervention versus had an AOT court order first and then transitioned.
Yeah, that's what I think I would be interested in, is what are the components of the LPS conservatorship before they go on to be the two individuals that were conserved. So that's
Right. And just to clarify, of course, for LPS conservatorship, it's different criteria than the housing conservatorship project
is.
that we were talking about.
Okay, yeah, no, that is helpful to clarify that. Yeah, okay. No, thank you. But that any further data would be helpful.
Happy to. I'll follow up.
Thanks.
Commissioner Chung, any questions or comments?
Yeah, it's kind of a question. So when you mentioned the demographic of like those who are currently like utilizing the programs, Do you think that cultural differences have something to do with who are more likely to call and seek help?
I absolutely appreciate that, and I have no doubt that there's a myriad of reasons that we see that, and we work very hard to make sure that we are providing culturally appropriate and competent outreach to communities to make sure that all communities are aware of that. And that being said, as you noted, because family members are one of our referral sources, and we see as being one of our primary referral sources for the program, I am sure that there are reservations of some cultural groups or community members to make that referral for court order treatment or intervention or that potential. And I think that there is always, of course, understandable concern and mistrust of some communities when it's involving the court. So we do see a predominantly Caucasian or white population for assisted outpatient treatment. And that's something that we always strive to do to make sure we provide that education and support. And that's a big role of our team members who provide that family support as well, to make sure that we are reaching populations that are in need of this intervention.
Thank you. Because like the reason why I asked that is, like the commission as well as, the department had prioritized health equity is an important issue and racial equity is the other. So I think that
Absolutely.
to really address that, I look forward to, one day, like when families of color will feel comfortable to use these services, consider how successful it is. It's definitely, like a great resource, especially for communities of color, in terms of helping them to get back on track and to the road of recovery.
Thank you, Commissioner.
I'd like to just go back one more time and just for my own understanding with the 25% referred to LPS conservatorship. What is that process? What are the services? And what if they're not overly cooperative within the treatment plan?
So of course, for LPS conservatorship, we're looking at the criteria of individuals needing to be chronically gravely disabled due to a mental disorder. And
Yes.
so the process can start at a couple of different locations. Individuals can either be referred for an LPS conservatorship while they are on an inpatient hospitalization, and so the treating psychiatrist would refer. There's also opportunities and pathways for treating psychiatrists in the community to make a referral. So for somebody who is not stable in the community and maybe is not acute and needing to go to the hospital, but is chronically gravely disabled and is deteriorating, for us to intervene more effectively and proactively in those cases. A community psychiatrist is able to file a petition. Petitions can be filed from the jail, and also treating psychologists are able to assess and file petitions. Of course, once that happens, the Department of Disability and Aging Services conducts an evaluation of the individual and a person's case to determine if they are moving forward. They have typically 30 days to do that, and then the case goes to court to determine that. Of course, an LPS conservatorship looks different than assisted outpatient treatment in terms of its authority. An LPS conservator is allowed to make treatment decisions or consent to behavioral health care on a person's behalf. It is unique, and this is not automatic, but they are also able to petition the court for an involuntary medication order. So if somebody really needs to be stabilized on medications, including long-acting injectables, it does allow for the conservator's office to request a particular authority through the court, and if granted, to consent to psychiatric medications on an individual's behalf. In terms of the treatment that individuals receive, again, that varies. Conservatorship allows for individuals to be placed and treated in a hospital or a lock-subacute treatment setting if that's necessary. But again, we always strive, as is our responsibility, to treat people at the least restrictive level of care, including many individuals being served in the community. And that includes very similar services, but it can include intensive case management services, residential treatment, peer support, medication management, other wraparound services to support people. I think I had mentioned in some situations, and we've certainly seen this in assisted outpatient treatment, is really the tool that allows us to support individuals to maintain permanent supportive housing and to remain stable in their housing. So really to remain safely in the community where they want to be and where they feel most comfortable, but need that additional support around making treatment decisions or taking psychiatric medications to ensure their stability.
Okay, thank you. I think I appreciate your explanation. It's a better understanding of the process.
Commissioners, is it all right for me to go to public comment to see if anyone's there?
Yes.
Okay, great.
Yes.
Person on the line, if you'd like to make comment on item 4, the assisted outpatient treatment program update, please press *3. Again, *3 to be recognized. All right, no hand, commissioners. Any more questions or comments from you on this item?
I'll have one more question. I hate to keep asking different questions, but with your AOT staff, do you have adequate staffing for the number of referrals, considering that there's been 200 new behavioral health hires through Mental Health SF?
Commissioner, I appreciate that. And I'll just say I'm happy to answer all of your questions. So no need to apologize for that. We were fortunate enough to benefit from some of that hiring. And so we do have some positions that we're willing to fill. And I'll say Dr. Wright does an amazing job across our work for both conservatorship and assisted outpatient treatment to make sure that our team members are cross-trained to provide that support. It's a little bit of a hard question to ask because we are so referral based that from year to year, the volume of referrals that we get can change. So it's hard to know the total number of what is needed. I think we've been in a pretty stable place in terms of staffing, but we are also looking to support larger work around, you mentioned care court as, a potential pathway that'll be coming our way. And
Right.
so we really work very closely within behavioral health services and of course with the mayor's office to identify the resources that we need to appropriately meet the needs of this population. The individuals that are served through housing conservatorship or assisted outpatient treatment or LPS conservatorship are of course a priority. These are our most vulnerable community members. And so we work very closely to make sure that we have the support that we need, which is a dynamic thing to assess.
No, I appreciate your answers, and again, it helps me in my job, sort of as a psychologist in some of the late teens and early young adults. I've had significant issues that require intensive case management, and so that's where I'm always concerned because it is such intensive work that you've got adequate staff to be able
Absolutely.
to do this. So thank you.
Thank you, Dr. Almeida. And also, Dr. Wright, I apologize for calling you the wrong guy. I think I didn't say doctor before. But thank you for both those items. And commissioners, we can move on to item 5, which is emerging issues. Any comments on this item? Okay, person on the comment line, if you'd like to make any comment on item 5, emerging issues, please press *3. All right, and then we're at item 6, public comment. Again, person on the line, this is the opportunity to speak about something that's not on the agenda. Please press *3 to do so. I don't see a hand, commissioners. And so now you are at a consideration of adjournment.
Okay, I'm going to just ask one more thing with the care court and emerging issues. As this legislation moves forward, if it's possible for Dr. Almeida to come back to us to just inform us of what the plan is going forward to meet whatever the previous what the guidelines might be. And as Commissioner Chunk had also referenced, since Governor Newsom is pushing this as previous mayor of San Francisco. I was on his, or one of the co-chairs of subcommittee on that 10-year homeless plan, which basically kind of went nowhere. So that's where I guess I'm just concerned that in going forward, that we're somewhat prepared or going in order in case he decides to showcase San Francisco. I want you guys to be the stars. So just that's my emerging issue and follow up for Care Court.
And I'll just say, Commissioner, I'm of course happy to have that conversation, and Mr. Morowitz, we of course can connect offline to see if it makes sense. I will say that I will be going out on maternity leave soon, so
For you.
timing may be a little complicated for me, but happy to figure out if we're able to make that work before I go on leave, as we learn more about what the Care Court will look like.
Okay, thank you very much, and an early congratulations for
Thank you.
maternity leave.
All right, commissioners, we're back at consideration for adjournment.
I move to adjourn.
I second.
All right, I will take that as action. Thank you all for the meeting. Thank you, presenters, and for the person who's attending from the public. And commissioners, I'll see you in about an hour.
Perfect.